ma'am, thank you for calling me. It's always, it is my honor to be here and really talk about. And another thing is RH, talking about RH is something which is so close to my heart. And I think this is what we do day in and day out. So I would request, like, whenever you have any questions on any slide, we can make it interactive. You can ask questions, any kind of questions. When we talk about RH immunization, we have to have a status check on this particular disease, right? So I would say that it is one of the most obliging afflictions. And trust me, when patients come to me, they come to me with so much anxiety. And we said, we'll manage. Don't worry about this. I mean, if you have to have something, have this. We can manage. So that's what it is, one of the most obliging afflictions. Why? Because it can be prevented by giving anti-D, right? Even if you have not been able to prevent and the patient has become iso-immunized, you can monitor it by MCA-PSV. There is a method to monitor. And even if the patient develops severe anemia, you can treat it with IUT, right? So nothing justifies a fetal or a neonatal loss to this condition. Nothing really. And yet we do almost 100 transfusions in a year. So what is really happening, right? Why are we at this place where we are today? So just, I'm sorry I missed, ma'am, your presentation, but maybe if there is some repetition, I think we can just, kind of go. Yeah. So first of all, let's understand why this is happening, and because this is extremely important to understand so that we have the concepts in place, right? So first of all, you have an RH negative mother. Right? Now, this RH negative mother is carrying an RH positive baby. So that's the basic problem, right? So an RH negative mother is carrying an RH positive baby who's carrying an RH positive antigen. Now, this antigen will cross over into the mother's immune system. Okay? Now, what happens in the first pregnancy? So when it is the first pregnancy, we know that the first antibody is IgM antibody. So it does not cross placenta. So most of the women who come to us do have one child, or unfortunately had a stillbirth, had abortions, did not take anti-D. So that's another reason. But the first pregnancy is usually not affected. Right? So that's one of the most important characteristics of RH isoimmunization. However, the subsequent pregnancies become worse and worse and worse because the immunization happens earlier. Now, once it is a second pregnancy, I don't know if you can see properly, but it is written IgG, right? Our second response is IgG. So that can cross the placenta and it will destroy fetal RBCs because it's an antibody to Rh positive and the fetus is Rh positive. So now it will destroy the antibodies. So then what happens? So in utero, there is hemolysis, antigen-antibody reaction, hemolysis, which leads to anemia, which in excessive form will lead to liver dysfunction, cardiac dysfunction, and hydrops fetalis. So that is what it can end up in an IUD, and it also can have polyhydramnios. So mirror syndrome is one of the severest forms where the mother is also having pedal edema, abdominal wall edema, and we've had cases who've had such severe mirror syndrome because of excessive polyhydramnios, right? So this is what happens when the baby is in utero. Now after birth, what happens? This hemolysis usually continues for some time because the baby is already having that IgG antibodies. The hemolysis is continuing. There is anemia, there is jaundice. Excessive jaundice can lead to kernicterus and it can also lead to neonatal death. So this is what is happening even after the baby is born, and that's why the problem. So eventually, how much is the risk? So it has been seen that the overall, if you don't give any anti-D, if you don't do anything, the overall risk of alloimmunization is 13%. But if you give a postpartum only anti-D, the risk falls down to 1 to 2%. And if you give both antepartum and postpartum, the risk is only less than 1%. Right? So yet we are having these problems. So another thing, why again we are having this problem? So yes, multiple. I think I heard some discussions about abortions. Yes. I think medical abortions, over-the-counter abortions, not knowing the blood group, one of the biggest reasons for alloimmunization. Then again, any other thing that you can think of for continued alloimmunization is inadequate dose is not really, we are giving 300 most of the time. So 99% of the time the dose is adequate. What else could be the reason? Storage issues. So if you're not maintaining the cold chain properly, then again that could be an issue. Also delay in giving anti-D, although you could give it till ideally 72 hours, even 10 days, up to 28 days, right? So again, that is something that is important. Another important thing is your site of injection. Where are you giving the anti-D? It has to be given in the deltoid. Okay, because if you give in the gluteal muscle, the absorption is not there. So some of the things why these things can happen, and yes, ma'am, there is only one RH anti-D now, and that is with these people. There is no other anti-D available in the country, and that is monoclonal, right? So there was a lot of issues with the polyclonal ones, and so we just have one anti-D, which is monoclonal anti-D. So that is what we use, and that is what we have to discuss. Now, let's just come to the basics on how to manage an RH negative pregnancy. So you have an RH negative pregnant woman. So you check the partner blood group. Now there's a big controversy on whether you should be checking the partner blood group or just do ICT. So there is a whole lot of people who believe ki don't do partner blood group, just do ICT. So that's a way of thinking, but it's fine. But our classic teaching is do the husband's blood group. If the blood group is negative, then we don't have to do anything. If the husband's blood group is positive, then we do ICT. When do we do ICT? 2 ICTs. One as booking, one at 28 weeks. If that ICT at booking and 28 weeks ICT is negative, then you give prophylactic anti-D, right? Between 28 to 32 weeks and within 72 hours of delivery, or any other sensitizing event, which we will talk about it later. If at any point in time the ICT becomes positive, we'll manage as RH ISO-immunized pregnancy. There is a small bit about paternal zygosity and cell-free DNA. Now, it is not something that we are routinely offering. There are very few conditions in which we offer. We'll discuss this later. But हम ये भी बोल सकते हैं कि बच्चे का blood group देख लें, cell-free DNA करके, and then we decide whether we give anti-D. Now, the testing for cell-free DNA is 20,000 rupees and anti-D is 3,000 rupees. So what will you do? But there is another indication to do it in RH ISO-immunized pregnancy. That we will cover later. So there is a bit of a role of doing this, and we are doing this in a number of cases now in a very specific situation, and we'll come to it later, right? So till now, any questions? We do have a lot of other scenarios will come. So we just discussed that placenta is a barrier in some situations, and RH positive cells, so these are the sensitizing events that we have to talk about. Threatened miscarriage, antepartum hemorrhage, amniocentesis, CVS, chordocentesis, external Catholic version, abdominal trauma, intrauterine death, and finally delivery and cesarean. Of course, we will think that these are the sensitizing events in which we must give anti-D, right? Now, how does this anti-D actually work? So, and also, you know, I have seen a lot of people in one pregnancy, my ICT is positive. I come in the next pregnancy, oh my God, my ICT is still positive. It will remain positive. Once your ICT is positive, it will be positive throughout. And trust me, we have seen patients being given IVIG to remove that ICT. Yes, steroids, IVIG, and when the titer is high, they've asked me for plasmapheresis. That can we reduce the titer of antibodies? So once the positive, it will remain positive your whole life. So it will not disappear because your immune system now recognizes it. So it will not forget it. So that is the concept that anti-D remains in the maternal circulation throughout life. Once sensitization has occurred, it is irreversible. However, there is no adverse effect on maternal health. It's not an autoantibody to the mother that it's going to cause some problem to the mother. So there is no problem. So this is what happens. Now, fetal RBC, so why are we giving anti-D at 28 weeks and not in the first and the second trimester? That's because fetal RBCs cross placenta in 5% of the cases in first trimester, in almost 50% by the third trimester, and 100% during delivery. So this is the reason that you give anti-D at 28 weeks and then you give anti-D at delivery, right? So And in Rh negative mothers, 1% are sensitized in the antenatal period and 10 to 15% are sensitized at the time of delivery. So this is the logic of giving anti-D at 28 weeks and at delivery, right? Then, of course, we talked about this. Now, prophylaxis is not 100%. That is what we talked about. So there could be multiple reasons that we discussed: excessive bleeding, decreased dose, no cold chain. Even if everything is okay, there's something called an antigenicity. Some people do have a greater tendency to react to it, and they can have it. So despite getting, and these are the population that we are getting increasingly. Women very well off who've received anti-D in the first trimester, in the previous pregnancies, and still getting alloimmunized. So no woman should be thought that, okay, isko nahi hoga, kisi ko bhi ho sakta hai. Our job is to give the correct anti-D at the correct time in the correct dose, right? So that is something which is extremely important. So this is called the RAADP. So routine antenatal anti-D prophylaxis, and these are the various guidelines that have recommended in all of these situations. Now, anti-D, initially the conventional anti-D was produced by a pooled plasma donors. However, now this is not being used. What we routinely use is your Rho clone or monoclonal antibody, which is the current format, and it has been seen that it is, it really works very well, and it's produced by the recombinant DNA technology. So this is something that we use at the time of delivery, after delivery or during the antenatal period. A little bit about precautions that we need to take at the time of labor and delivery. You have given anti-D at 28 weeks. And you're managing it well. At the time of delivery, we must avoid methergin. So you do a routine active management of third stage of labor using oxytocin. Do not try and avoid manual removal of placenta. At the time of delivery, we have to take the cord blood sample, see for the blood group of the baby. Okay. Now, if the blood group of the baby is negative, then we don't have to give anti-D. Again, DCT, direct Coombs test. Direct Coombs test means that the mother has antibodies which have crossed over to the fetus and they have lined the RBCs. So if the direct Coombs test is positive, again there is no role of anti-D. So after delivery, if the baby's blood group is positive or direct Coombs test is negative, then we will give anti-D. Is that clear? No confusion about it? So these are the basic things. In any Rh negative mother, at the time of delivery, cord blood should be taken and this should be documented, right? Again, 300 microgram within 72 hours of delivery, it is to be given. And like I said, preferably 72 hours, at least 10 days, or even at least 28 days. Something we should give, if not anything else. So now we come to the situations where, what are the other situations which you can discuss. Sometimes in conditions like intrauterine fetal demise, abruption, bleeding placenta previa, or MRP, if you've had to do, sometimes the amount of feto-maternal hemorrhage is more than what you expect. And these are the situations in which you must try and do a KB test to see if our feto-maternal bleed is more than 30 ml. So in that situation, we might want to give additional, but unfortunately, KB test is not easily available. It is not standardized. So it's a manual test, and even our blood bank doesn't offer. We do something called the Rosette test, which is still more standardized than the KB test. There are some labs who do offer, but it's far and apart. So when we suspect in such patients, we do give them. The ideal test in such situation is flow cytometry, which is very expensive. So if you're really, really thinking, then in that case, we can ask some labs who do the KB test. At our place, we do a Rosette test and see if it is excessive. So these are the situations in which you might want to give extra anti-D. Now, there is something called a DU, which is a weak D antigen, and it also tests as positive, right? And in that case, if it is positive, even so, it is not usual that these patients would result in an alloimmunization, but still you should give anti-D. Right? Even if it's a weak D, sometimes you'll get a report of a weak D antigen, but still you should give anti-D to prevent alloimmunization. Now, I think there was some discussion about threatened abortion. So Our practice is give anti-D to everybody. Let's not have any confusion. Yes, there is some theoretical information which says that if your abortion has been at less than 6 weeks, spontaneous, complete abortion without medication, without instrumentation, you might not give anti-D. But we'll come to it, ma'am. Yes. So first thing is, this is the very, very exclusive criteria. Why? The basic concept is RH antigen is manifested at 7 weeks in the fetus. So if a fetus had a spontaneous miscarriage before 6 weeks, then there is no chance of alloimmunization. So you might want to leave it. But in that case also, if you've done some instrumentation, if you've given a medical method or a surgical method, you should give. So for us, we give to everybody. There's no harm in doing it. You should know the theory, but practically we give it to everybody. Again, the dose, of course, is 150. If it is anything which is less than 12 weeks, you can give 150 if it is available. Otherwise, see, giving 300 doesn't harm anybody, right? So let's not get into the nitty-gritties. Ideally 150. If you don't have, give 300. So that is.
I just wish to know, all government hospitals apply?
Yes, JSSK, ma'am.
Yeah. Mandatory.
Yes, yes.
28 weeks.
Yes.
Antenatal.
But you will be surprised to know how little across the country people get antenatal. Postnatal coverage, in a recent study, which was the Rhythm study, which has been done by this along with a lot of centers from the country, the postnatal coverage is good, but antenatal coverage is woefully small. It's like only 15% or so. And that's because most of the people would not even do ICT. That's the, yeah, so first test karao, fir uske baad do. So most of the people are not doing. So, I mean, here we have an elite group who can do ideal practice. But worldwide, I would say countrywide, it's not such a great practice existing which is there. So these are the various guidelines. All ACOG, RCOG, FOXY, SOGC, all say postpartum, there is no confusion, 300 microgram within 72 hours of delivery. All guidelines. When you have a sensitizing event, which is less than 12 weeks, so you will give around 50 to 150. If it is more than 12 weeks, you give 300. So these are some of the variations for sensitizing events and less than 12 weeks, right? So whenever in doubt, give 300. That's very simple. If you have any doubt, give 300 because we know it's not harmful, right?
Aparna, एक दो पेपर में recently आया जो question कर रहे हैं antenatal. So what is your?
Yes. So even RCOG has questions the antenatal. So like you said, worldwide, it is not a problem of the West. So if you are giving proper antenatal, eventually the thing comes down. Our problem is even the postnatal is not being done well, right?
No, situation in UK is
Yeah.
our ESI hospital are doing much better in terms of economics
Yeah.
than ours.
So they will question everything, yes. So, I mean, and plus what happens is for them, if you put them in the guideline, the government has to pay. So everything will be questioned, but I don't think we must look into their,
It's only the financial criteria. There is some other scientific.
So basically what the recent studies have found that the additional advantage of giving postnatal, antenatal to postnatal may not be very, very high. That is what they have found. It in one of the studies. Say for example, if we do not give anything, the risk is around 13 to 14%. Now, if we give only postnatal, the risk is 2%. If you add antenatal, the risk comes down to less than 1%. So yes, so 2 to 1%. Yes. So that's what they say, that how much of an advantage you're adding for the burden that you are putting. So it may be valid if you look into the economics of it and regarding the efficacy. But I feel that we are so low down on the bar that we should not even think about that right now. So that's something that we...
जब gynecologists आते हैं तो यहाँ का तो सब कुछ आता है। वो ये बताते हैं UK ये हो रहा है।
हाँ. Currently I feel that our medical system is much more better advanced.
Yeah, I agree.
I would come, yeah.
More accessible.
And I would say that, God forbid you fall sick in any of these places.
Because
It is pathetic. You can't. I was in the UK emergency for 6 hours. Nobody saw me. And despite having so many contacts. So I feel that, yes, we should be proud of our own medical system. And there is no less malpractice anywhere. So I really feel that we should be at least sticking to standards, but let us also look into how the standards have been made, why the standards have been made, and what is suitable to us. So that is something that we must be aware of. So I will not really say that let's not think of antenatal. I think we must encourage antenatal detections. Now, in molar pregnancy, what do you think? Now, as you know, molar pregnancy does not have a fetal tissue, right? Yeah. So that's what it is. So sometimes if it's a partial mole, it does have a fetal tissue. So again, when in doubt, give anti-D. But if it's a complete mole, you can avoid it. But that's how it is. But give anti-D. There is no doubt about it. We give anti-D. What about ectopic pregnancy? Yes. So 24% of the women have had some immunization. It's questionable on how it happens, because sometimes, pregnancies may cross 7 to 8 weeks, even in an ectopic pregnancy. And then there is an antigen which is there and which gets circulated. So in ectopic pregnancy, give anti-D, right? Then there is another question that suppose a patient is having threatened abortion, and she's continuing to bleed. And I think that's one of the most difficult situations that we face, that how many times should we give anti-D? Yes. So also there is a small way to know. So patient had bleeding, you gave anti-D, right? Now it's, say, again a second episode of bleeding the patient had, and it is maybe within 3 weeks or maybe after 3 weeks. So essentially what we also suggest is do an ICT. If the ICT is negative, that means your anti-D is gone. Okay. Right? So if your ICT is negative, your anti-D is gone, then you give another anti-D. 3. Yes. So ma'am, if your anti-D has been utilized by the bleeding, then it will go. So then you give. Right? So it's just a simple way to understand that you are not missing out on anything. If you have given anti-D and you are within 3 weeks, you are relatively safe, right? But if it has been 3 weeks and suppose you had some excessive bleeding even within 3 weeks or after 3 weeks, then you just get your ICT done. If your ICT is negative, give anti-D. So that's another way to look at it.
I want to ask one thing.
Yes. Yeah. 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 You should give one single dose of anti-D, and if there is no further bleeding or anything, no. So later on also, yes, single dose you will give. Yeah. Yeah. So I mean, you need to. But ma'am, so that's give the benefit of the doubt. If you think it is there, which is actually like done by a good ultrasonologist, and you are reasonably sure of the diagnosis, there's no harm in giving. So same concept. 3 weeks. If you have, so there you don't do ICT. If you have given, suppose patient you gave anti-D at 29 weeks or maybe 30 weeks, and the patient went into preterm labor at 33 weeks, then within 3 weeks there is no need to give. And suppose for some reason you gave at 35 weeks and the patient delivered at 37 weeks, within 3 weeks there is no need to give. Beyond 3 weeks, give. Repeat anti-D. It has been seen that it is there. So generally it has been seen that it stays. So within 3 weeks. So that is what. So if you are within 3 weeks, and unless you are suspecting excessive bleeding, right? Yeah. No, not twins. Twins is okay, the same. But if you are, say, abruption, okay, in that situation, possibly you would like to, do a KB test and give. But within 3 weeks, it is reasonable that you don't have to give. De do. No, the additional dose, yeah, second dose you could give even 450. 150 ka bhi aata hai. So depending on the bleed. Okay. हाँ. You have 150. 150. Yes. So if you have given, so like any IUD, abruption, MRP, where you think that the FMH will be, fetal maternal hemorrhage will be more, then you can repeat it. Yes, so that is again why madam is saying, why do you want to give in IUD even before the delivery of the baby? The patient, RH negative patient. Yes, so in IUD, if you're suspecting that the reason could be an abruption or you could see some placental reason, then it is logical to give IUD the moment you diagnose it, right? To not wait for delivery, you can just give it when you diagnose it. Is anti-D immunoglobulin indicated in sensitized pregnancy? तो फिर अगर आपको लग रहा है कि IUD सेंसिटाइज प्रेगनेंसी की वजह से हुआ तो बिल्कुल ही नहीं देना है, क्योंकि वो तो वेस्ट है, वो तो हो चुका है, तो फिर वो वेस्ट है. So in a sensitized pregnancy, there is no need to give anti-D prophylaxis. ये question ऐसे ही बीच में है, अभी we will talk about the sensitized pregnancy. Yes. So ideally, if you want to do pregnancy in IUD, so you can do an ICT, right? So if you've given already, so then in case the ICT is positive, then you don't give, right? If the ICT is negative, in an RH negative mother coming with an IUD, you can do an ICT and see if the ICT is positive, don't give anti-D. In any situation in which the ICT is positive, don't give anti-D. Madam is not convinced at all. Okay, we'll come to it again till the time that you are convinced. These are the recommendations. We'll talk about it again, right? Now, this is the second part where we come to the sensitized pregnancy, okay? Now, this is your sensitized pregnancy. Your ICT titer has come positive. At any point in time, if my critical titer has reached, what is my critical titer? It is 1 in 16, right? So, if it is less than 1 in 16, say it is 1 in 2, 1 in 4, 1 in 8. So, I will do a repeat titer every 4 weekly, right? If, however, the critical titer is reached, then in that case, no further ICTs. And this is something that has to be really followed. अब वो टाइटर चाहे आपका 1 in 16 है, चाहे 1 in 2056 है, मुझे कोई टेंशन नहीं है. I have absolutely no qualms about a high ICT titer because I'm not going to work on it, right? I will not give anything to reduce that titer. So it doesn't matter if it is 1 in 16 or 1 in 2056, no further ICTs. What you further do is, more than 35 weeks, I will deliver. And if the gestational age is less than 35, I will give IUT. Right?
ये सारी summary है.
हाँ बस यही है बस और आगे पीछे कुछ करने की जरूरत नहीं. Yes. If, however, it is on your repeated tests, your critical titer has not reached, then you repeat ICT 4 weekly till 24 weeks and 2 weekly till term. Okay? But will you give anti-D in this arm? Somebody will give. You will think, madam, you will give anti-D? No. नो मैडम फिर अब ये एक और क्वेश्चन, आपने कराया क्यों? आपने अगर आईसीटी करा 28 वीक्स पे और एंटी-डी दे दिया, उसके बाद क्यों कराया? हाँ हाँ, सो दिस इज अनदर ऐसे ना गड्ढा खोद के उसमें कूदने वाली बात होती है. हाँ हाँ है ना. और अभी
इंजेक्शन भी दे दिया और फिर भी आईसीटी
बिल्कुल, और पेशेंट मैडम मेरा पॉजिटिव आ गया, हम इसी का तो वेट कर रहे थे वो लोग. हाँ करा के आता है. सो दैट इज अनदर पिटफॉल. नेवर डू आईसीटी वंस यू हैव गिवन. हाँ फिर कंफ्यूज्ड. सो हियर never do ICT after you have given an anti-D, and never give anti-D if the ICT is positive. So everything, so even if it is say 1 in 2, that means the immune system has recognized it. अभी 2 है, अगली बार 16 हो जाएगा, अगली प्रेगनेंसी में 32 और 128 भी हो जाएगा. The immune system has recognized it. The anti-D, how does it work? The anti-D will actually line the RBCs so that those are not presented to the immune system. अगर एक बार वो प्रेजेंट हो चुका है, उसके बाद आप चाहे कितना भी लाइन कर लीजिए, वो तो पॉजिटिव ही रहेगा. ओके? यस, यस, बिल्कुल बिल्कुल. नॉर्मल प्रेगनेंसी तो मैम अभी दिखाएंगे पॉजिटिव. तो मैम आईसीटी पॉजिटिव है तो अब आप एमसीए डॉपलर करेंगे, क्योंकि अब आईसीटी पॉजिटिव हो गया है तो हमें पता है इस बच्चे को अनीमिया हो सकता है. तो अब हम वेट कर रहे हैं कि अनीमिया हो रहा है कि नहीं हो रहा है, और वो डिटेक्ट करने का तरीका अल्ट्रासाउंड है. अब ब्लड टेस्ट खत्म. सो आईसीटी पॉजिटिव में अगर मेरे पास 100 पेशेंट्स होते हैं तो 60% ऑफ द टाइम दे डोंट रिक्वायर आईयूटी. Only 30 to 40% of the women will require IUT because of multiple reasons. Husband may be heterozygous, this baby may be negative, right? और इतना ज़्यादा एंटीजेनिसिटी ही नहीं है, पूरी प्रेगनेंसी निकल गई. And especially the first RHISO immunized pregnancy, majority of the women will not require IUT. They usually require it in the second or the third, or if they've had previous abortions in which they did not, that increase the sensitization, right?
This is good news. आपके पास एक तो बच्चा है, हाँ, दूसरे में इम्यूनाइज होने तो आईटी जरूरत ही
नहीं चाहिए मैम. 60 to 70% ऑफ द टाइम, मतलब हमारे पास एक दिन में, जब मैं अल्ट्रासाउंड, आज मेरा डे है, 15 पेशेंट आते हैं, एटलीस्ट 15 to 20 पेशेंट जिसका हम एमसीए पीएसवी मॉनिटरिंग करते हैं. उन एमसीए पीएसवी 15 पेशेंट्स में हम आईयूटी सिर्फ 5 का कर रहे हैं, है ना, बाकी सब निकल गए. और आजकल तो हमने बुक करना भी बंद कर दिया है. हम कहते हैं आप मॉनिटरिंग करेंगे, अगर सब ठीक है तो डिलीवरी बाहर करो, हम नहीं करा रहे. अगर हमने आईयूटी दिया तब हम डिलीवर करेंगे, बिकॉज वी आर ओवरलोडेड विद दोज थिंग्स. So this is what we say, we will monitor you, we will guide you, but if you have not required an IUT, you deliver outside. So there is a absolutely very good chance that you have no requirement for IUT, right? So that's the crux of the matter. Oh. Now, how to monitor? So like we said, MCA PSV's Doppler, I think this is one of the easiest Doppler to do. And why MCA PSV? Why this vessel? Actually, yes, that's the only reason. Every vessel has increased velocity, but you can insonate the brain very nicely, so that you can do it. आराम से 0 degree मिलता है इसमें angle for insonation. So you just have to go to the base of the brain. You got the cerebellum. Just उसके नीचे जाना है, where you start seeing the sphenoid bone here. Just put in the color, put in the power Doppler, and then you get a straight wave where you can see. And a simple thing is, even if you don't do your ultrasounds, how many do ultrasounds yourself? Even if you don't do ultrasounds yourself, look at the value. And a rule of thumb, अगर किसी gestation पे means middle cerebral artery peak systolic velocity is more than 2 times, there is anemia. So अगर 24 weeks है और एमसीए पीएसवी का वैल्यू आपको रेडियोलॉजिस्ट दे रहा है कि 48 या 50 है, और वो पता नहीं क्या एमओएम लिख रहे हैं, आप बोलो कि ये तो अनीमिया है. जेस्टेशन का डबल है या उससे ज़्यादा है तो बच्चे को अनीमिया है. सिंपल. सो उसको ट्रांसफ्यूजन लगेगा, तो टाइम टू रेफर फॉर थेरेपी. अब दिखता है मैम, हाँ. सो this is very. So another thing that what we are doing now also is, can we delay IUT? So basically what happens is that, suppose we have patients who are coming to us in this pregnancy with high drops at 18 weeks. It's a nightmare. What can you do? You actually start transfusions around 16 to 18 weeks. तो अगर 18 weeks पे high drops होता है तो ना बच्चा दिखता है, ना कॉर्ड दिखता है, ना कुछ दिखता है. तो अब हम next pregnancy में उसको 14 to 15 weeks onwards weekly IVIG देते हैं to postpone IUT, ताकि hemolysis का रेट थोड़ा स्लो हो जाए. So that we do for a maximum of 7 doses weekly IVIG that we are giving. We admit and give because फिर वो फ्री में मिलता है JSSK के अंडर मदर को. और it's a very high dose because it's 1 gram per kg. So अगर 50 grams का मतलब एटलीस्ट हम लगाते हैं तो 25 करके 2 दिन में लगाते हैं. And the cost comes to be around 4 to 5 lakhs per dose. I mean, we should thank the government of India for, and इससे हमको फायदा मिलता है 2-3 हफ्ते का. But that decides the timeline between successful and not successful. I would say, ma'am, we get so many transfusions. So I feel in the last 1 year, we must have done 25. Makes a difference. No, ma'am. We are, I mean, these things. So in this particular situation, it makes all the difference between a live baby and a IUD. Yes. Yes. So in these situations, so we call them $1 million babies, but yeah. So, but we do. Oh, extreme situations. So if we are doing 100 transfusions or 150 transfusions, maybe we do it in, say, 10 to 15 patients.
Do the patient know that this much?
We make sure that they know. Yeah. So generally we start from around 15 to 15 weeks after the first trimester, and we give it weekly, maximum 3 to 4 doses हम देते हैं, ताकि जो 18-20 हफ्ते वाला critical, उसके बाद तो हम IUT कर लेंगे. Success, हाँ. So that is what we do. So this is something, this gives us some advantage of 3 to 4 weeks. So we choose our cases very carefully. I mean, we don't give it like just like that. So we decide, okay, now she had so many, we have 8 people who have had 8-9 pregnancy losses. So that's what we do, right? Now, the blood is, of course, we take an O negative blood, which is irradiated so that, the reactions are less. The fetal volume, how much of blood volume, it really depends on what is the weight of the fetus. So say, for example, there is this method which I will just show the table directly here. So now these are tables which are available. So if you have a 25-weeker woman and she has an anemia, a hematocrit of less than 30 is considered anemia. So if she has, say, a hematocrit of 25 and you want to increase it to 50, our target is 50. So the desired increase, how much do I want to increase? So if I want to, say, increase by 18% at 25 weeks, then in that case, the volume, if I want to increase by 10%, I have to transfuse 18 ml. So there are tables which tell us how much, but on an average, the interesting fact is that if suppose you have a baby who's 1 kg, so uska fetoplacental volume is 0.14 into the weight, so 140 ml. So if I am, say, 60 kgs, my blood volume is around 5 liters, right? Similarly, for a fetus who's 1 kg, the blood volume is 140 ml. हम लोग उसका 1/3 transfuse करते हैं. So around 40 to 45 ml. So that's how we calculate. That's a rough calculation that we do. So, and interestingly, when the baby is born, you have to do an exchange transfusion. आप जितना डालते हो उतना निकालते हो. But fetus में तो हम निकाल नहीं रहे. क्यों? Because the fetus has placenta. So the blood goes into the fetoplacental circulation so that there's no immediate pressure on the fetal heart. But still, if a patient has come to us with high drops, that means there is heart failure, then we transfuse only 50% of the desired volume at one time. And then we do transfusion every 3 days. So that thoda karke, we will, yes. So that's how we calculate the volume. The target hematocrit, like I said, is around 50%. We want to take the hemoglobin to, say, around 13, 14. Okay, and anything which is less than 10 is anemia. So we do it under local anesthesia, no local anesthesia, no sedation, no antibiotics. If a patient is, say, after 28 weeks, we do give steroids before taking the patient for procedure. And we paralyze the baby using vecuronium. So we first put fetal thigh, injection into the fetal thigh so that the baby will sleep off and there is no movement. And then we do the procedure. So where do we do the procedure? Normally at the umbilical cord insertion and sometimes in the free loop of the cord. So the loose umbilical cord, and increasingly now we are doing in the liver, fetal liver. Now Western trend is liver zyada, but we have been trained by Dr. Deca, who was just put the needle into the cord. So people are surprised that our free loop is more than our liver. So, but that's a trend. Liver, doing into the liver is simpler. So this is how we do the intrauterine transfusions. So the yellow needle is the spinal needle. This is the vecuronium, which is the fetal paralytic agent that we have taken. And the blood, as I said, is O negative, irradiated, and it is called double centrifuged because its hematocrit is 80%. It is twice that of the normal blood. And we generally preload the blood into syringes. We generally have an idea of how much is the blood volume that we will transfuse. This is more like an OPD procedure. We call the patient in the morning, transfuse, and maybe we can send the patient by evening or by the next morning. Now you see here, this is the tip of the needle going into the fetal thigh. So that's an intramuscular injection that we give. And after that, we wait for some time so that the baby will, become quiet. And now you can see that this is the anterior part of the cord insertion where we will start the transfusion. So this is an easy kind of a procedure because you have anterior placenta and the cord insertion right there. But sometimes even when you have given the vecuronium, the baby will keep on moving. So sometimes it becomes difficult to do the transfusion. But still this is anterior placenta, so it's all right to do a transfusion. Now you can see that this is a posterior placenta. However, the baby is showing the cord insertion and not sitting on it. Sometimes the baby really sits on the cord insertion. So that's how you do the posterior. And this is a nightmare that I was talking about. 18 weeks, high drops, big placenta. This is a placentogmegaly. You can hardly see the cord insertion, but you have to. So these are the cases in which in the next pregnancy, if baby wants to conceive, I will give IVIG because she had high drops at 18 weeks. So again, so this is the liver of the fetus, and where we are going is the intrahepatic. So this part is well supported. It has liver on both sides. So when you remove the needle, there is no back bleed. While in the vein, when you do, there is a back bleed. So that's the fetal liver, and you can do the transfusion there. Increasingly, this part is also becoming easier to do, and this is an advanced gestation, late gestation, big liver. So there also you can do the intrahepatic transfusion. And once you are inside the cord, you will take the sample, and we have hemocues. You will do hemoglobin then and there. And depending on the hematocrit, so if the hematocrit is say 25 and I want to increase it to 50, then I will use that factor of 0.5 and multiply that with the fetal weight. So I will give 1000, so I'll give 50 ml. So that's how I will look at it. And then we push the blood. At the end of it, again, we will take a sample to confirm what is the hematocrit, and then we will plan the further transfusions. On an average, usually patients require 2 to 3 transfusion. It could be 7 to 8. Following transfusion, again, MCA PSV is done weekly. Normally, what we take is rate of fall is 1% per day. So if I have increased that to 50 at say 25 weeks, I will wait for it to fall to 30, which will take 20 days. So 3 weeks. So I do the next transfusion after 3 weeks. Now, to be safe, I will also look at the MCA PSV. Generally, after 2 transfusions, MCA PSV is not very good because now it's not the fetal blood, it's all adult blood. It's not getting destroyed, but it has its own half-life. So we take it both ways, both rate of fall of 1% per day and MCA PSV. We will look. If it is increased, then we will again transfuse. When do we deliver? Earlier, I think 5 to 7 years back, we would do the last transfusion at 32 weeks and deliver by 34 weeks. But our neonatologist really questioned us, then why are you giving us so many preterm babies? So they said, hum khade hain, you do the last transfusion at 34 to 35 weeks. If there is fetal distress, we are ready to take the baby inside. So now I do my last transfusion at 34 weeks and 6 days. And till that time, I will wait. Beyond that, I won't. So if I do the last transfusion at 34 weeks and 6 days, I have 2 to 3 more weeks to go. So all my deliveries now we do between 36 to 37 to 37 plus weeks. So, but it is really, really difficult because one is you can't see anything, you can't see the cord, you can't see, there's a lot of fetal parts happening. We always give steroid, we inform the nursery, we always have a cesarean section backup, OT available. We make the OT list wait, that okay, I'm doing IUT, wait for it. So that's what we do. So again, the last part is that it is technically challenging to do the late transfusion. So that's why not many people would do it, but it is good for the baby to take the baby till 36 to 37 weeks. And that's why we would do about it. And So this was actually about the procedure. Would you like to ask any questions up to this point? If there are any questions.
The reason of sudden intrauterine death.
Lots of reasons, I would say, yeah. So complications?
There's no other
Yeah.
association.
So basically, you have to go into the vein. If you go into the artery, there will be a
Not
procedure related. Yeah. Generally, if you've corrected the anemia well, they do well. There is no problem. Sometimes we've had cases where there was associated oligohydramnios, all good, no anemia. This happened last, I think, 6 months back, and we could not understand. She had a sudden IUD. But then she had previous losses also. So sometimes we have RH alloimmunization with APLA. That's like a deadly combination. So we have had 3 cases who had RH alloimmunization with APLA syndrome with multiple pregnancy losses. So all of those things will possibly, cause. But otherwise, procedure related, if it has gone well, it is usually okay, but every procedure has its problem. So that's what I was said, that in God we trust, but all others bring data. So when we talk about our results, we see more than 100 transfusions in a year still. And the IUTs have only increased. So the last 66 was the COVID year. When we were in a lockdown, we did 66 transfusions. So that was despite the lockdown. But the good part is that the percentage with high drops has come down. So you see less and less number people are coming with high drops, and that's really good part about the referrals. So mostly we get now referrals at ICT positive, and we good referrals from centers also when the MCA has increased. So that's also good. Like, people ICT positive, they start monitoring, and when they feel that the MCA is raised. Across Delhi, there are so many good people who refer that I have been seeing this patient and now I think MCA has raised, please take over. So we take over. So I think that's again an increased awareness that, okay, you don't let the patient go into high drops. Now, if you talk about the survival following IUT, so it is 95 to 96%. Yes, and this is what we need to tell the patients, that even if you have required IUT, and this 96%, 96% is after high drops. So even hydropic babies will survive. It's just that we need to refer them on time and, manage it well. Procedure-related pregnancy loss is around 2.6% now. So it's not very, very high. So this will happen in any patient in which you put in a needle. There is always a risk of some problem or otherwise. So, but then this is one thing which provides good treatment. And in our last publication, we have reported 95 to 90% survival rates. So that was in 2020. And very recently, this came in the JOGI, where we talked about 2 decades. So we talked about more than 1,000 transfusions that have been happening, and overall survival is around 95%. So if we manage this situation well, there is no reason to expect that the outcomes are not going to be okay. So then, of course, we always say regarding RH alloimmunization that the tenets are intensive monitoring, fetal blood transfusion on time, and referral. But before I end, I would like to say this, that there are only 5 pointers to the right management of an RH negative pregnancy. Was blood group done for the pregnant woman? If her blood group is negative, was the husband blood group done? If the husband blood group is positive, was the ICT done? If the ICT was negative, was anti-D given? And if the ICT is now positive, has the patient been referred to a fetal medicine center on time? So if we remember these 5 things, we can't really go wrong in the management of an RH negative pregnant woman. So I think that is all I would like to say from my side. And I would like to acknowledge Dr. Vatsala Dadwal and Anubhuti Rana. We are a team who are working for this in the Division of Maternal Fetal Medicine at AIIMS. Thank you very much. So the thing is, you have to know that RH system has 51 antigens. And D is only one of them, which is the most frequent. The reason why you should do the others is the other atypical antigens may be present, and this may cause alloimmunization. And at AIIMS, we are doing it regularly, but we've not really detected anything which we have not expected very, very alarmingly. But as a practice, it is recommended, because only D is detected when you are doing a mother who's D positive or a D negative. Other 51, you are not doing. And if patient is, even if it is D positive, she could be negative for something else. And that's what I'm going to tell in just 3 more minutes, right? Now, this case was 1 in a million case, actually, which brought together social service, fetal intervention, blood bank. Okay. Now, this patient was 27-year-old, 8th gravida, live 0, 3 abortions, 4 losses, 8 pregnancies in her 7 years of marriage, 4 intrauterine deaths, and 3 abortions. She came to us at 19 weeks of pregnancy, and interestingly, जिस दिन से वो आई, वो सिर्फ डिलीवरी करके घर गई है. She was with us throughout pregnancy because that was her situation. Now, her first pregnancy, she had eclampsia IUD, second pregnancy, high BP IUD, third pregnancy, hydrops IUD, fourth pregnancy, hydrops IUD. In the fifth pregnancy, she went to Lady Harding. Lady Harding said that you can't match her blood group. So she was sent to AIMS. In AIMS, she came with an IUD, but the blood bank told us that we can't find the blood group. And this is something else. So this was the case in which they said we can't even manage it. How do we do it? So now we delivered, thankfully, no blood loss. We delivered, sent the patient home. We said, don't conceive till you get a blood group. And then वो मैच ही नहीं हो रहा है, वो सबके साथ वो कर रहा है, hemolyze कर रहा है. So you could not type the blood group. What blood group is it? So she was D positive, but her ICT was positive. The blood was hemolyzing with every blood group. Yes. So then she was asked to avoid conception. उसके बाद उसने 2020 में फिर से abortion किया और फिर से conceive किया in the 8th pregnancy without telling us, and then she directly came at 19 weeks to AIMS. मतलब ये absolute contraceptive failure भी है, but that was the situation. So when she came to us, her MCA PSV was already raised, so she was anemic. क्या option हमारे पास क्या थे? That could we do plasmapheresis? Could we have given IVIG? Could we have done IUT? So we gave IVIG, but IUT we wanted to do, but which blood? कहाँ से आएगा? So we gave IVIG, but then she developed hydrops. 21 weeks. So 19 to 21 हम लेकर गए, but 21 weeks पे hydrops हो गया. COVID pandemic चल रहा था, and there was lockdown everywhere, and like she landed up in hydrops. So if we wanted to do transfusion, which blood group? कहाँ से आएगा? So then this is the phenotype actually, that she is D positive, but she is actually RH17 negative. So like I said, there are 51 antigens. So she was negative for RH17. And this was achieved by sending the patient's blood to Bristol. So there is the International Blood Bank Genotyping Center in Bristol. So our blood bank people sent it, and they said this was RH17 negative. And this is called D double negative, negative phenotype. Now this in Japan is found in 1 in 1 lakh people because they type it. We don't know in India what's happening. No Indian data available. Interestingly, ये ना donors का panel होता है कि क्या कौन से donors हैं. India में there was 1 donor, Japan में 32 donors, and I talked to that donor. He refused to give blood. He said, I will not give. I said, we'll give you money, we'll give you travel, we'll give you everything. I personally literally pleaded him to come. He said, I will not give. No, India wala. And this person lives in Ghaziabad. And I called this guy, and I even said that, we will arrange your travel, we'll give you an award, we'll give you money, whatever. He didn't come. 1 unit. Mana. He refused. So I said, see, whenever you require, where will you get blood from? But still he didn't come. So he refused to donate blood. Then they contacted Japan Red Cross. They said they will send the blood. But the problem is blood is an organ. Right? So you need a lot of documentation. So this was, and all of it we are sitting on hydrops in COVID times. So there was no time, but the Japan people said we will send. And all of this, our team in 1 day, MS office, director office, everybody cleared the documentation. But the problem is blood is an organ. So you need to actually give 2 tickets, one for the transporter, one for the blood. So we had to have 1.5 lakhs. 1.5 lakhs. So then we got it, and then there was this company, Relaxo Chappal, company, our MSSO contacted a few people, then they got the blood and they gave the money immediately. And for the first time that company gave, later on there's something called a Rashtriya Arogya Nidhi, the scheme. Yeah, so they gave us up to 5 lakh rupees. So we transported blood 3 times from Japan in this pregnancy. And this is how, so this was the total cost around 4 lakh 10,000 rupees. And with that, we did 6 times intrauterine transfusion to this woman, and hydrops resolved after 3 IUTs. And then, yes, so it was done almost 2, because hydrops tha. So the dates are written here. So if you look at it, one was on the day of Christmas, we actually asked the sister to open the OT and do it. Because we got the blood one day before on 24th, and on 25th we did the transfusion on a holiday. And 3 days, 3 days, 3 days. So once the hydrops resolved, then we did that after a month, and then in February. So it's like 6 transfusions. However, at 32 weeks, again, she had a drop. So this was not a very reassuring fetal heart, but there was no blood. So there was only one blood which we could give to the baby, but there was no blood for the mother. So for this, what we did for the first time also is autologous transfusion. So before doing a cesarean, we took the blood from the mother and normovolemic hypovolemia. So we replace the same amount of fluid into the body, keep the blood for the mother. Then we did the cesarean. Thankfully, the mother did not require a transfusion. So we retransfuse the blood into the mother. So this is called autologous transfusion. So our blood bank guided us that, okay, hum ye to kar sakte hain. So that was a big risk. And then both the mother and the baby were all right at the end of the whole thing. So I think this was 3 cycles of sending to Japan, donation in Japan. 30, yeah, so the baby had IUGR, but the baby, this ICT was positive. Karna chahiye. Right. So, yes, I mean, this kind of things, although rare, you can detect. So after that, now I have another patient of RH17 who's following with me. We have contacted, done the necessary things. So now we are more experienced, and yes, we have contacted this lady and she is ready to donate blood for her. Yes. So that's how we have planned. So this was actually the first successful case of RH17. Very few cases have actually, because it's got a very, very increased antigenicity. So this girl was called Tapasya. So, so thank you very much. And I think that's what we were at the role of ICT.